Anyone hear me? Just gonna give it a few minutes before we get started here. So, does anyone have any questions so far on any of the content that we have gone over? So, just wanted to give a few minutes to get everyone situated here before we get started talking about psychosis and some of its um, treatments. And looking over some mechanisms and some specific things about them. Um, so, anyway, if you guys don't already know, my name is Snehal Desai, and I will be going over this presentation with you all. So, um, if anybody has any questions or suggestions or comments you'd like to add, can you feel free to use the chat box here. Um, it's not a whole lot of things in this section, but as we have already talked about in the previous lectures, a lot of the information does kind of connect concept-wise. So we'll talk about some of those connecting concepts in a few minutes. Um, I'm just trying out something else to see if we can get something working here. So just give me a minute. as we conclude on the overview of our um, topics that pertains to neurology and psychology and psychiatry uh, and its related medications, um, we will be doing some brief overview of all the topics that we have covered since the beginning of this course. So it can be very helpful or useful to some of you as you prepare for the boards exams and as well as you're going to practice and all of that. So let me um, go over this first, and then in the future lecture we'll go over all of that as a second review of topic coverage, or a list of topics that we have um, reviewed so far in this course. So give me just a few minutes here. Okay. So, hello. Um, so Okay, so let's just get started here. Um, um, as some of you are might be waiting for me to get started on this presentation here. So, this topic right here, as you see on the screen, is on schizophrenia. Um, Schizophrenia is actually kind of a little bit of a broad topic here. Um, because it's not specific to a disease like you would see as someone having seizures, Parkinson's, Alzheimer's, dementia. Um, this one is kind of like a combination of all of those kind of topics, but mostly symptom related um, as you will see shortly. Um, a lot of it in this section, it deals with the dopamine receptors. And I'm sure some of you may have already listened to my previous lecture on Parkinson's disease, and you saw how carbidopa and levodopa are needed to ensure that, you know, levodopa can get through the blood-brain barrier and so forth, and become a get converted to dopamine, and then does its mechanism and and its relevance and helping treat the Parkinson type of symptoms, Parkinson disease treatment as well overall. So um, this section kind of relates to dopamine, but in the essence, it actually is used to work in two different pathways, which you are about to see in a little bit. Um, One of the pathways go through the mesolimbic pathway, and the other one is the mesocortical pathway. So, in both of these pathways, specifically deal with the dopamine receptors and um, its related um, parts as well. And as you'll see shortly, the medications here, there's two generations, um, which I'm going to show you now. Give me a second. Let's look over the definition first here. So basically, schizophrenia is a severe brain disorder. And what happens, it causes psychosis, impaired thinking, social dysfunction, functional decline. So it's kind of like a combination of Alzheimer and Parkinson's a little bit. Um, and it may involve like glutamate and serotonin and dopamine. A lot of the medications here play a role mostly with the dopamine and the serotonin receptors, um, particularly the D2 and the 5-HT2A receptors. So, you're going to see a lot of those types of receptors used in many of these medications that's used to treat it. And you'll understand why in a minute. But some of the symptoms that a patient having schizophrenia could get are things like hallucinations, delusions, disorganized speech, some agitation. These are mostly like positive symptoms. What do I mean by positive and negative symptoms? Negative symptoms are more like um, someone who's not able to kind of have much effect, hallucinations, delusions, things that they could see. It's like something's just going on in their head. And the other one is negative, it's like nothing's happening, or kind of like they're just not able to respond to anything here. So they're going to have some sort of flat effect, avolition, and hedonia, and alogia. And these are mostly like the negative symptoms a patient will experience where they're not able to respond to certain things. Um, It's kind of like blank for them. Then cognitive symptoms are gets more to severe stage. They're not able to execute anything at all. So they poor executive function and their memory impairment. And so um, on the right here, I kind of have a table kind of outlining the differences here, the mesolimbic and the mesocortical pathways. You can see in the mesolimbic pathway, um, there's an increase in dopamine levels. And so there's going to be more positive symptoms. And when the dopamine levels are lower, there's negative symptoms. So what we want is a balance between both. And so this is another really nice illustrated diagram that I think might help some of you all so you can kind of see how positive and negative symptoms and those like that, where these kinds of events might occur to a patient when they're having these symptoms. Um, so just keep in mind, some of the differences here, understand what the different pathways are. Um, I would think when you think of mesolimbic, probably thinking of kind limping or jumping, or probably there's an increase in that dopamine, too much dopamine going out of the neurotransmitter and going to other neurotransmitter and those kinds of things. So there's going to be more positive, more hallucinations. You're going to have more delusions. You're not going to be able to speak properly, or feel more agitated and things like that. So I just wanted to give you a little more um, visual idea and maybe some cues that might help you understand these differences. So what are some mitigation tactics? Um, Thinking about these kind of things, you want to think about some receptors that need to be blocked inside the nervous system. And so um, the main one here you might want to focus on are things like this. Let me kind of draw it out here, maybe the dopamine. And really just this 5-HT2A receptor, the serotonin receptor. Um, really want to make sure that the EPS symptoms are lower and not to really increase there. That's like things like tardive dyskinesia, where a patient might be experiencing some uh, um, uncontrollable, like tongue slapping movement or things like that. So it's very important when it comes to this, and also want the antipsychotic effect as well. Now, sometimes medications might kind of interact with this and this receptors as well. Patient might have very high blood pressure, so it might kind of help them when they want to take a medication, just not to get too low, or at least orthostatic hypotension. Or if they're taking a, they want to try to have good night's sleep, lean to more sedative effects, maybe some anticholinergic effects, but too much anticholinergic is not good. So, but it's good to at least have an idea so you guys can see how all of these receptors, when blocked, can lead to these kinds of effects. The main ones here are really the antipsychotic and the EPS effects that we want to see more of rather than the others. So here's a diagram that kind of breaks down the um, pathways um, between the mesolimbic and the mesocortical pathways. Now, this is not really the best diagram here, but at least you can kind of see how some of those pathways where they're going, which part of our brain, and those kinds of things. Just to give you an idea. Um, and so the most important part here of our uh, presentation here are on these medications. Now, in practice, you may have seen some of these medications used many times, haloperidol being one of them. You probably may have seen something like risperidone. You probably may have dispensed a medication, olanzapine, quetiapine, and so forth. But you could see how these two are kind of divided between first generation and second generation antipsychotics. So, what's the main difference here? And you're about to see this in my later sections. But the main thing is the first line therapy for psychosis is generally going to be the second line antipsychotics. Um, and that's mainly because of the one receptor that um, these antipsychotics um, use, but they also use an additional receptor too, whereas the first generation only used a single receptor. So um, that's a main difference here. Um, there might be some other things that you probably know about that might make them different from each other, but really you would see more of an increase of EPS symptoms when taking the first generation than the second generation antipsychotics. Now, this diagram kind of explains a combination of um, medications in the second generation class of antipsychotics that's used. As you can see, I drew kind of two different neurotransmitters here, showing the differences between mesolimbic and mesocortical parts of it. Now, in the later diagrams, you're not going to see so much of this, but at least in the purposes of this presentation, I just wanted to make sure to you guys had an understanding of um, at least the differences here between the two different pathways of the brain signals here. So take a look here, and risperidone and olanzapine are really great examples here because they kind of work very similarly. Both of these medications interact with the dopamine or the D2 receptor. And both of these medications are going to antagonize or block those receptors, specifically in the mesolimbic pathway. So, why are we doing this? Because, dopamine, as you saw earlier, an increased amount, an abundance amount of dopamine in it doesn't have to just be specifically for mesolimbic, but also mesocortical. It's going to lead to more uh, concurrent or increased, or actually increased amount of positive symptoms. And as I mentioned earlier, positive symptoms are going to lead to more hallucinations, delusions. You're going to have more of that kind of thinking, so, we want to kind of limit the amount of positive symptoms by blocking those dopamine receptors. On the other hand, in the mesocortical pathway, you have these serotonin receptors, and these serotonin receptors we want to block so we can actually increase our dopamine output here. So on one side, we want to have our dopamine increase where there's more negative symptoms. On the other hand, we want to decrease the dopamine, really, so that there is less positive symptoms. So essentially, we want to balance of those two. Quetiapine also blocks the same receptors, but they also block alpha 1 receptors, so it might lead to more orthostatic hypotension. Um, the histamine receptor, each one. So there might be more sedation, might lead to more, um, might help patients at night to sleep. So you might see some of those kind of additional things, about these medications. Sometimes patients use this for sleep. It helps them sleep. That's why they would take something like Seroquel, um, because of the increased sedation. Also, Seroquel being used as like an adjunct in the major depressive disorder or bipolar depression. Um, so it's generally, a good idea to have an understanding of these kinds of things as well, um, just so you guys can see that here. So let's go over the ziprasidone. So what is significant about ziprasidone? Um, think of zapping someone like with electrostatic or electric um, wire, or like a static kind of, you're try and touch a doorknob, or kind of like rubbing your feet, or try and touch a doorknob, and then you kind of like get a shock. So essentially, I drew it in a way so you guys can kind of see it. It's not the best diagram, but you can see how ziprasidone kind of have a little bit connections with the previous topics we talked about. Now, remember I talked about how the neurons kind of align with each other, and kind of um, how it kind of shows an action potential. So essentially, an action potential gets started because whenever there's a neuron, there's going to be some potassium already in there by default in the axon or the soma, and those kinds of parts of neuron. So what happens here is ziprasidone. Yeah, it does block the dopamine, does block the 5-HT2A receptor as well, just like you've seen in the previous diagram. It also blocks some serotonin and norepinephrine transporters, also alpha 1. But it also blocks something called a potassium channel. And sodium, as you know, typically when it goes inside a neuron, it actually depolarizes that neuron, so it can cause an action potential and then signal downstream um, through other neurotransmitting pathways. And so when we're talking about like cardiac cells and heart, and I'm sure some of you have already learned about arrhythmias, um, whenever there is arrhythmias or something like that, there's always some sort of electrical impulse. But here, when ziprasidone blocks those potassium voltage channels, it's going to prevent the potassium from being released and repolarizing. So it will not go back to resting state very easily. So in that essence, it's going to prolong the um, action potential. So it's going to increase the duration of it. What happens then to the heart is it's going to eventually lead to QT prolongation um, because of this delayed repolarization. So, um, as you have seen, whenever there is action potential, you see a lot of these other neurotransmitters released, dopamine, serotonin, all that kind of stuff. Well, that's in the brain, but in the heart, it's a little bit different. This can also kind of affect the heart as well, leading to that QT. So I just wanted to kind of show you that because I thought it was really interesting that this medication has an effect on the heart. So, um, it kind of connects with somewhat previous sections we looked over. Then aripiprazole. This medication has where it partially antagonizes um, or acts as like a partial agonist, I guess, in the um, around the dopamine and the 5-HT1A receptor, and it antagonizes the 5-HT2A receptor. So in a way, you're going to see a little more stabilization here in the dopamine and the serotonin levels here. So you can improve the negative and the positive symptoms this way as well. I don't think you will see it has more of a stronger effect on the 5-HT2A receptor, but at least you guys can see that here. So I thought it was interesting to talk about that here. So if there's any medication that has some kind of partial agonism, it's going to be the aripiprazole here. So you don't have too much blocked and not too little, blocked kind of thing. So it kind of works out. And then the clozapine. The clozapine blocks many types of receptors here. Dopamine 2, dopamine 4, D2, D4, receptors, and also the 5-HT2A receptor as well. You could also see some other receptors blocked here, like the histamine 1 receptor, the muscarinic, the alpha 1, and the 5-HT2C receptor, where there might be some other effects. Now, histamine, if that receptor is blocked, might lead to more of a weight gain, sedation, as you saw previously with Seroquel and quetiapine. Muscarinic antagonists, some anticholinergic effects might occur there. Alpha 1, so someone can have orthostatic hypotension when they are taking this medication. And the last one, I don't think we talked about much, but it can lead to some metabolic issues. And then obviously weight gain, another issue here too. So this medication is pretty interesting because it does involve some additional monitoring, especially when it comes to metabolic and hematologic functioning. Hematologic meaning maybe something's not right with like the blood cells and things like that. So it's it's an interesting drug. It's one of the drugs that might require additional like um, monitoring, particularly like the ANC values and things like that to keep that within range, and um, checking the RAMs as well on this medication. So just want you guys all to know about that. Um, so then the chlorpromazine, these are the first generation antipsychotics, all three of these. They all block the dopamine 2 receptor, which is what makes them different from the second generation, because second generation blocks the second receptor. You can think second. So second receptor, which is the 5-HT2A and the serotonin part receptor parts. But this one, chlorpromazine, also blocks some other interesting receptors here, similarly to like the other ones. But all of these first generation receptors that's being blocked is going to potentially lead to more of a EPS symptom and such. Um, APS is essential extrapyramidal symptoms, and these are things like it can lead to neck twisting, jaw clenching. Patients cannot sit still, so they might have constant pacing, tremor, rigidity. So I want you all to see it, just so you guys have an idea, and that's pretty much it. If anyone has any questions, feel free to message me and let me know, and we'll go over it. And as I mentioned, we will look through all the other topics, and kind of outline everything that we've looked at since the beginning of this course. So hopefully that kind of helps you all out. And thank you very much for watching. Hope you all enjoyed it, and I personally enjoyed talking to you all about all of these different um, topics and information, give you an overview, an idea of medication usage and information, and some of the um, receptor structures, and like understanding how the medication works, which will actually explain the why part when it comes to understanding the symptoms and side effects and all, um, as it relates to case studies, and specifically when you look at those case studies, you kind of have an idea based off the mechanism how the medication works, so you can kind of connect the dots together this way. So I hope this has been kind of clear for you all, and you guys had um, a, a an overview as on these topics as you um, go through them. So if anyone has any questions, would like to comment, suggest anything, uh, you know, if you guys want to give any reviews, feel free. Um, and also, uh, just let me know. But thank you very much, and I hope you all have a good day, and we'll see you next time. Thanks.